Hi, good morning. As you're joining, any questions that you have about delivering MAT via telehealth implementation or payment, go ahead and put them in our Q&A box, and we will make sure that we get to them. Hi, Vivian. Nice to see you. Hi, Sophia. Nice to see you. All right, so I just want to go ahead and make sure that everybody can hear us. So Jill, if you can see this, or Aria, can you just let me know, just send me a Slack or a chat to the webinar just telling me that we're all set? And then, hey, I just unmuted you. Okay, great. All right, seems like we're good. So, okay, great. Awesome. Well, good morning, everyone. My name is Elizabeth Keating. I'm the program manager for California Bridge, and we are so excited to bring you this learning opportunity today based on the sheer interest in this topic right now in this moment that we are living in. So today we have an expert group of presenters who are going to be talking to us about implementing MAT using telehealth, including the question that we get over and over again that I know you're all dying to hear more about, which is how we actually get paid for this. So welcome. I see that based on our attendee list, we have a pretty strong group of California Bridge physicians and substance use navigators. So I encourage you now and as we continue to hear the presentations to go ahead and use the Q&A function in Zoom. So you should be able to go to the Zoom panel, click on Q&A and put your questions in, and we'll make sure that the participants get to those either as we go or toward the end. So we are leaving a lot of time for Q&A today. Our three presenters are going to share just a small fraction of what they know with you in order to be able to take as many questions as possible. So we are going to get started, and just as a regular disclaimer, this is being recorded today, and we do plan to post it on the California Bridge YouTube channel when that is available toward the end of the month. So to review the people and topics we're presenting today, we have Rebecca Chotsky-Sir, who is a California Bridge Regional Director with a focus in LA County. She'll be talking about LA County's approach to telehealth. Casey Grover, who's the ED Director at CHOMP in Monterey, Community Hospital of the Monterey Peninsula, and John Zweifler, who is an expert who's been working with Bridge for quite some time, has been doing telehealth at his recently former site, Adventist Health Hanford, and is going to be sharing with you how we can do this and maintain revenue. So just a review, some little tricks about Zoom. You are currently all muted, but if you do want to talk and ask questions in person or ask follow-up questions, you can raise your hand using the Zoom raise hand function, and I'll see that and I'll go ahead and unmute you. We would love to hear from you. You also can use the chat box if you want to talk to each other or to share something informal. Use the Q&A to tell us what your questions are about this topic. You can also do this from mobile. You have all the same capabilities on mobile. And then just a reminder to use this as a way to connect with each other. So, you know, we really are missing the in-person trainings we used to hold with California Bridge. So use this program as a way to stay connected with each other. You all have so many best practices and interesting stories and implementation tales right now coming out of all of your hospitals. We do have a contact sheet that we've made available. If you'd like to reach out to each other, I can always connect you to each other. And just so everybody on this call knows, California Bridge is in the midst of strategic planning to really be able to determine what direction this program is going to go in the new healthcare reality, both financially and implementation wise, and with the changes that have made under COVID-19. And I don't have anything too official to say about this right now, but part of that strategic planning does involve some advocacy to get the funding back in the budget that was that we encourage you all to apply for to secure your substance use navigators. So if you're on this call and you're wondering about the fate of that funding and what we are doing, you will be hearing from us very, very soon. So within the next day or so, we're going to have some more to say about that and a call to action for all of you. Just a reminder that all of our resources are on bridgetotreatment.org. And in this moment where I know a lot of hospitals are re-looking at the way that you do things, that might be a good opportunity to, on some level, go back to the basics. And if you do want to go back to those basics, those toolkits are available on our website. If you're newer to MAT implementation, there should be something there for everybody, regardless of what kind of questions that you have. All right, so with that, I will turn it over to Dr. Rebecca Trotsky-Sir. Hi, Rebecca, good morning.
Good morning, everybody. How are you doing today?
Good, that audio sounds much better, thanks.
Is it working?
It sounds great.
Okay, good. Excellent. So I am based in Los Angeles, and we've been working on providing health equity in the form of equal access or equitable access to addiction medicine services in our public healthcare system for a number of years, and preparing to roll out a telehealth service prior to COVID. And then when COVID hit, that really provided an opportunity to expedite and move through. So our vision came from this very broad concept of how do we provide the most amount of services to the most amount of people in an efficient way. And I just wanted to do our process and kind of some of our operations, and then be available for questions for you. So next slide, please. So our like vision and having a clear vision, I think, is really important, and then backwards casting what your goals need to be. So our vision was to provide immediate evidence-based life-saving care for substance use disorder, specifically medication for opioid use disorder, for any patient, anywhere, anytime, really agnostic of empanelment to a healthcare system, to a patient's health plan and a payer, and be really human-centered in this process. So recognizing that a lot of our patients are living in Skid Row or interacting with helping professionals that may be outside of the hospital box. So initially, we were focused on a lot of our technological solutions, like, should we use Google Voice? Should we use a different kind of, pager system? Or what is the technology we need to implement? And not too long of a time, but what we really needed was a kind of model, in the sense that this is a very hyper complex question environment with a lot of shifting problems that needed to recognize the culture of practice in a wide range of facilities and a wide range of cultures and a wide range of practice norms across our care setting. So next slide. So I think we can all share that vision that we would love to be able to provide, buprenorphine as the technological answer for most opioid use disorder for all of our patients. And there's a lot of barriers to that. It's a controlled substance. There was a lot of barriers. Not everybody encountered a prescriber that was X-flavored. So we had this vision along originally with having this X-flavored prescriber of the day that could be a reference point for anybody in our system. And we wanted to expand that to include our community health workers and our street outreach services. And so, we have some technological solutions that we came with that we want to share with as low cost. So for example, we kind of a call pool of 5 to take calls that last 24 hours, and each of us can port in our personal cell phones or our work cell phones to the Google Voice, one single phone call or as like a single origin point, but that goes out to a lot of different providers. That was one of our technological solutions. We use Amiana's shift management so that we can all easily know who's on call. we had to figure out a lot of these operational kind of hurdles, credentialing across multiple sites. So I'm credentialed at our public healthcare hospital, LAC USC, in the ER department. And in order for me to prescribe controlled substances for patients in other settings, I needed to get credentialed in their settings as well. We are going through some technical hurdles. Get back to our screen share. Thank you. EPCS stands for electronic prescribing of controlled substances. So that's both a tool. So that means I can be at home and electronically prescribe to any pharmacy in the county. And it's also a hurdle in that it's linked to where my patient's encounter is. So we just had to think through a lot of these operational technical barriers. And we had to think through how we're documenting in our electronic medical record, our EMR, and which providers were documenting in which kinds of encounters. And ultimately, we had to think through what are the lowest, fewest number of steps that a provider needed to do in order to register in the community and not registered already in the healthcare system. So in that way, we developed a number of documents that then we share across teams to address all of these things. And what we've developed allows us, street outreach service team across the county, encounter a patient who is using drugs and offer them to call us as providers in the street. And then we are able to register that patient that moment in the healthcare system and document a conversation and prescribe medications to that person at the nearest pharmacy wherever they are. So Los Angeles is a very geographically wide county, so we had to figure out how to provide medications to people even if they were 10, 20 miles away from wherever the provider was, and to think through helping people pay for those in commercial pharmacies, for example. Now, one of the things after solving all those technological hurdles, we thought we were golden. And what we learned was that there was a lot of cultural challenges, such that we assumed we'd get a lot of supporting calls from all the clinics that don't have X-waivered prescribers. And it turns out that if a clinic does not have X-waivered prescribers, it also indicates that they're not necessarily aware or interested in medications for substance use disorder. So we had to kind of go and support the culture change in all the regional network. It's not just a lack of an X-waivered prescriber, but it's the culture shift that needs to happen from these outreach services and outreach teams and our clinic network. We had to identify pharmacy friends, we call them. So these are our pharmacies in the community that are in alliance with this concept of prescribing medications for patients who might have dysregulated behaviors or unusual appearances because they're living in the streets, and making sure that those pharmacies had buprenorphine and naloxone available at time of ordering within 30 minutes, and not oh, we have to call our sister pharmacy in a different area and get it shipped to us, and that person can come back in 3 days, because we knew that our patients needed that medication, that phone call within a couple of minutes. So we had to do outreach and build relationships with pharmacists and change culture there. And then we did a lot of work kind of supporting our community health workers, our CHWs, which can also be substance use navigators, but they don't have to be, to understand that they can support a patient getting medication and picking up that medication for the patient, for example, and bringing it back to the tent or wherever that patient is. And then really supporting that patient, having a longitudinal relationship with a primary care provider, ideally buprenorphine capacity, or we can be the buprenorphine capacity for a good care provider. Concept of where does this person go for the long term? Our hotline number is always available to continue prescriptions for as long as possible, as long as needed. The best thing for a patient is to connect with a long-term engagement stuff. In terms of sustainability, we're looking to really hold gains in telehealth liberalization that happened with COVID. So some of the challenges that we had prior to COVID liberalization were the need or the perceived need for a face-to-face visit controlled substance prescribing, at least initially. And now that's liberalized, so we can just make a phone call visit, and that really supported access. And then, of course, how do we continue paying for people's medications if they're in a random Rite Aid, in a random part of the county? Right now, we just basically Visa cards that we give out to our community health workers to purchase the meds, but that is just a short-term solution. And in terms of like paying for our docs, like it's not a huge amount of money that the pool of providers make, but it is, enough to feel like we're not constantly volunteering on this issue. And that is a sustainability question over the next year or two. How will we continue doing that? Making sure our street outreach teams and our services that are not just MAT related are sustained over COVID times is another question we have. And then ideally, our big audacious goal is that a patient could call this line no matter what and get through to a provider without having to connect through an intermediary of a helping professional. So right now, the phone number is designed for a helping professional to sit with the patient wherever they are to connect to the providers. But in the future, we would like to make this, I could call from my home at 3 in the morning and get to a provider who can prescribe me buprenorphine. So that's kind of a quick what Los Angeles County has rolled out. It's been up and running now for about 2 months. And it's definitely been a goal that we had in mind for a number of years. So happy to go through any of our technical or cultural solutions that we had and see how they can work for your system. So
Great. Thank you so much, Rebecca. And I'm going to change the guidance I gave at the beginning, which is if you have questions for Rebecca or for others, please put them in the chat. You can send them to all panelists, and I will make sure they get seen that way. So any questions you have for Rebecca about the model that she built in LA County, go ahead and put them in the chat. And so Eileen at Adventist Health in Rideout, one of our California bridge sites, is asking to get straight to the point, how did you pay for all of this? So Rebecca, do you want to speak to that before we move on to the next couple speakers who are also going to be answering this question for their own stories?
At this point, the funding for NV's provider time is grant supported, and it was like all the different sites that contribute providers providing support for that provider, and it's not as low as a couple $100 a day to take a 24-hour call. And I anticipate that we will continue to have grant support for about a year, and then we will work on the process so that a lot of our patients do have Medicaid, and we can enroll people in emergency Medi-Cal. Because a lot of us are in the ER department. And so I think that is going to be our model of funding, although Los Angeles County is such a complex beast in terms of funding that I can't guarantee that our funding shenanigans will be able to directly translate into your solution. So that's why I think we have some really great experts on this panel solutions for your site.
Yeah, that's a really good transition. Thanks, Rebecca. So we'll bring you back for the Q&A in just a couple minutes. So Casey, you want to tell us about what you did at CHOMP? Things look a little different at a community hospital versus a county-wide initiative. Tell us what you did, and we'll take questions.
Absolutely. If you want to move forward, and I made a couple of slides. So I apologize for my goofy title here, to boldly go where no one has gone before. And I will give apologies to my colleague, Dr. Reb Close, who does not like any science fiction. I didn't realize this was a Star Trek quote when I made it, so I apologize. I'm the medical director of the ER at Community Hospital of the Monterey Peninsula. I've been prescribing MAT for about 3 years now. And Rebecca, it was very nice to hear you talk about Skid Row, because I used to work at needle exchanges on Skid Row when I was a medical student in Los Angeles. So I've always kind of had an interest in substance use as a population to be taken care of. And we're a small community hospital, about 250 beds. ER has about 56,000 visits a year. And when we first heard the news of what was kind of happening globally, and then next in our nation and next in California, we really wanted to get creative in how can we save PPE and how can we get people care without having to use the traditional brick and mortar model for seeing patients in our ER. And so I had a couple of physicians who basically said, you know, we need to think outside the box. So let's go to the next slide, please. So what we built was basically an emergency department telehealth follow-up program. And this is for all comers, but is particularly useful for MAT. And so basically we looked at how can we see a person in the emergency department and see them via telehealth in some way from their home with one of our providers in 2 days or a week or whatever it is for a recheck. And telemedicine is really interesting. I mean, telemedicine is like, the analogy would be is it's like a car. You might have a sedan, you might have a van, you might have an SUV, you might have a truck, you might have an American, you might have an import, you might have four-wheel drive. There's so many permutations and ways to do this, and yet all of them still qualify as telemedicine. So this is one particular way that basically we came up with a process that works for our institution. So we initially kind of thought through what do we need to do to be able to build this new model. So the first is our providers designed it. And there are two physicians, and I'll give them credit at the end of my slides, said, look, we've got to get creative. People are going to be fearful of the emergency department. There's an opportunity here to save PPE and still get people follow-up. We also, as physicians that work shift work, vary in who's working when. And we have a wonderful person who basically coordinates our group of physicians at our emergency department. And I will give her credit at the end of my slides as well. And she was willing to coordinate it. So if I'm working today and I see someone who I induce on buprenorphine and they need a follow-up in a week, our practice coordinator, I send her a secure message and she's able to coordinate it. The next part, and this was probably the biggest lift, is how do you register people for an ER visit when they're not physically in the ER? And it really was an interesting question of, we've never done that before. How are we going to do it? And so we actually, and I'll go through the details of that, but we had to kind of break the mold of what we've done previously. And the other thing that was also really interesting is how do you get people's consent to bill their insurance? And how do you get their consent for treatment? And how do you kind of make sure that all the legal nuts and bolts have been addressed? The next kind of moving part in all of this was the IT and EHR part of this. And I saw two things come up in the chat. And so we use Epic. Sorry, I can't hide my opinions there, but we do use Epic. And to their credit, our information technology team did an incredible job building basically an alternative emergency department workflow. So I'm logged into Epic right now. And on our track board, we have a separate segment of the ER called ED Telehealth. And these patients are registered for an ER visit and they show up on a totally different part of the track board and they're tracked totally differently. And we ended up using a platform called Doxy.me. That's DOXY, like the antibiotic.me. And it's a free HIPAA compliant video conferencing software. And it's really easy to use. Really easy to set up an account. Really easy to give people the link to get into their encounter. And really the only major issues have just been that as we went to Doxy, the rest of the medical kind of community in the country also looked at them. So for a period of time, our connections were a little bit slow, but there's totally other options. There's Zoom, Doximity, which is a physician kind of pseudo social media app can do it. There's lots of different ways to do this. Again, my analogy, you need a car. There's so many permutations. The same applies to telehealth. And then the last piece was hospital administration. We needed to be able to go to them and say, this is what we want to do, and this is why it's a good idea, and this is how it'll save PPE, and this is how it'll keep patients and providers safe. Next slide, please. So this was really kind of our biggest sticking point. And how do we register people for an ER visit before they show up? And everybody's got a different practice. My practice is we are a small democratic physician group. We run our own corporation, and we only work in one place. So it wasn't as though, like in a county hospital system, and I don't understand the nuances of many other hospitals, but you might be able to say, oh, no problem. The ER will see them and the county clinic will follow them up. we were stuck in that we are really some of the only physicians in our hospital system that have MAT waivers. So we have, I think, 12 doctors in my emergency department that prescribe buprenorphine, and that's compared to, I think, one in the rest of the organization, maybe 2 or 3 if you include psychiatry. So really our group said, gosh, if anyone's going to be taking on telehealth MAT, it's us. So I had to have several phone calls with, hospital administration. We call our registrars patient access, health information management, our documentation folks, health information technology, our IT folks, and then my legal department of how do we do this? How do we get consent? What's the process of registering them? And we really found that you need to kind of pick the patients that are going to do best and want it to make it work. And then we had to come up with some standardized language. Next slide, please. So in Epic, we basically created a standard documentation template. And this is the equivalent to a signed consent form for a virtual ED follow-up visit. And my physicians are super annoyed with me because it actually turns out that a lot of times reading this consent form takes longer than the actual visit itself. But these questions needed to be answered, and we need to be able to have documentation that if someone files a complaint or someone has a grievance, you consented and we told you what we were doing. So for example, question 1 is basically, are you okay if we use telemedicine? Number 2, are you okay if we record the video and document in your medical record? Number 3, we may share some of your information as a part of our standard medical practice. And number 4, we are trying to maintain social distancing and reduce exposure. Are you okay if we bill your insurance since this is replacing an in-person visit? And so this is what my hospital, just kind of on the fly during COVID, said, that seems pretty reasonable as the equivalent to a signed consent to do a telehealth follow-up visit instead of an emergency department visit. Next slide, please. We also realized that there's a lot more to telemedicine than just the technology and the documentation, namely that schools are closed and our lives at home are very different than our lives from work. So we found a couple of pitfalls. The first is some patients do not do well with telehealth technology, even how easy Doxy.me is. I mean, I love my mother, but my mother just cannot figure out how to do anything involving technology. And so if you told my mother she had to have a telehealth visit, I would have to physically go to her house and supervise the visit to make the technology work. So that's the type of person that we may want to come up with another plan for. I also have a couple of providers in my group that are really tech savvy and they love it. I have a couple of providers that can barely, figure out how to send a text message. So trying to kind of pair tech savvy patients with tech savvy providers. The other thing, and I don't know if my screen right now of the video on me is able to be seen, but you can see what's happening behind me. There's a printer behind me. I think there's some boxes. And if you're at home in your pajamas and your kids are bothering you, that's not a very professional environment. And we had to really create kind of an etiquette to providing telehealth. And that meant finding a professional looking environment. And the gentleman who's speaking after I am has a really nice looking background, and we actually talked about it. You can really kind of choose your background to look professional and make it feel more like a traditional visit. Bad Wi-Fi is always an issue, so really testing things out before you do them. And then the last thing that came up, and I'm almost finished, comes up with the fact that from an ER standpoint, there's a revenue stream for the hospital of a hospital facility fee. So if someone comes into the ER just checking in, there's a facility fee that's billed to use our facilities. As a doctor, I see the patient and I generate a professional fee. And going to telehealth only, you eliminate the facility fee and you only have the professional fee. And so as hospitals are losing money, folks are going, that doesn't seem right. So it turns out, and I just am looking at this right now, there's actually something called a telemedicine originating site facility fee. And just because I mumbled there, a telemedicine originating site facility fee. And it sounds like the hospitals can actually bill a small facility fee to help with some of the revenue loss by doing virtual visits. And we haven't actually gone live with that yet here. I just sent an email to my chief medical information officer to start looking at that. Next slide, please. All right, and this is my last slide, and I just wanted to give some follow-up of what we've been doing. So we rolled this out basically for all cases in the ER, cellulitis rechecks, bad-looking laceration rechecks, as well as medication-assisted treatment. And we really wanted to make sure it worked. So we did 18 cases between April and as of May 1st. And 8 out of 8 people we surveyed gave us a 5-star rating. And I just texted our practice manager today, and we've had 41 scheduled and 36 completed. And looking at Epic, we're scheduled to do 4 today. So this is growing. And I have to give credit to Doctors Bakta and Kruger-Kalinsky, since they were the 2 physicians in my group that really spearheaded this. And then Kavitha Weaver's our practice coordinator, who has really made this happen. And that's all I've got.
Great, thanks a lot. So I see a couple questions coming in through the chat, but I think that a lot of them are related to what Dr. Zweifler is going to talk to us about. So let's hear from you, Dr. Zweifler, and then we'll make sure we get to all of your questions today. Oops, we have you on mute. Go ahead and unmute yourself. Your audio should be beautiful. There it is.
Okay, good. All right.
Perfect.
Well, thank you very much, Elizabeth. And so it's a pleasure to be speaking to everyone about this topic. It's so dynamic right now with what's happening in our society and healthcare, and let alone with MAT and telehealth, that I'm going to speak relatively broadly. The other reason I'm going to speak a little bit broadly about this is because I am a physician, a clinician, and have done a lot of medical administration. I'm not a biller and a coder, so we're not going to get into the weeds on that. But I do want to look at this in terms of both where we were before COVID, and this was a hot topic before COVID in terms of telehealth and MAT. Talk about what's happened with COVID, which has been dramatic, and then talk a little bit about the future and what directions we might go. So with that as background, let's dive in. Next slide, please. Okay, so telehealth and MAT, there's a lot of questions about this. In fact, we were trying to set up a webinar regarding this several months ago before COVID-19 hit. And the reason why there's a lot of angst is that there was a law passed back in 2008 called the Ryan-Haight Act, which basically said that you could not prescribe any controlled substances through the internet. And so, of course, MAT, so if you want to prescribe buprenorphine with telehealth, then you'd be running afoul of the Ryan-Haight Act. So this was definitely a hindrance to expansion of telehealth. In 2018, there was an effort to address that. There was legislation passed called the Support Act, which basically said we want to encourage and support telehealth. We want to encourage use of MAT, and we want to break down those barriers. So it was the intent of Congress and signed by our president that we would try and address this issue. They did talk about creating a registration system, which was supposed to be completed within a year. Since that time, we've had a number of the major agencies weigh in on this. So first of all, DEA came out and it said that if you were a physician or a clinician and you had your controlled substance license, you had your DEA license, you had your Waiver-X, and you were practicing in conformance as a controlled substance provider, then it was okay for you to use telehealth services. So they're basically saying, from a DEA perspective, as long as if you have your DEA certificate, you have your Waiver-X, DEA do not want to create barriers to you using telehealth. HHS came out and had another memo also in 2018, which said they were working with DEA to also to encourage the use of telehealth to support medicated assisted treatments. CMS has also weighed in on this by creating billing codes, specifically this year, creating billing codes around bundled payments that are really most appropriate for treatment centers, but specifically addressing the fact that you can use telehealth for MAT and providing specific billing codes around bundled payments that treatment centers could use. And then finally, the state of California has also talked about, do you need to have a prior in-person visit? And they said, no, that would not be required. They even said it doesn't even have to be a synchronous visit. So you could theoretically do this through an email exchange, according to the state of California. So the bottom line is, even before COVID-19 hit, we had the concern about the Ryan Haight Act, which prohibited use of the internet to prescribe controlled substances. But then you had Congress, the president, DEA, HHS, CMS, and state of California all come out with pretty clear statements supportive of MAT, using telehealth to provide MAT. So there's a little bit of gray area in each one of them. And so you could say, geez, did we dot all the I's and cross all the T's? Well, maybe not 100%, but the intent was clear from all of the major players who are overseeing use of controlled substances and healthcare services, that yes, we want to encourage telehealth. We want to encourage medicated assisted treatment. So next slide. So then we all know what happened. The coronavirus hit, and everything changed overnight in so many different ways. And certainly it affected me personally as well. But as it relates to digital health, what we have seen is an absolute explosion of digital health since the coronavirus hit. It is probably the most dramatic transformation that we have seen in healthcare, certainly in my lifetime, where all of a sudden all bets are off and telehealth is okay. And it's my belief that even after COVID-19, we're going to see that the telehealth genie is out of the bottle, because it is so much more efficient and so much more efficient in so many settings that it's going to be very hard to roll that back. So what was it that was inhibiting telehealth? And I'm speaking more broadly than just the MAT issue, because based on what we talked about before, I think it was less the MAT issues, I think, have been addressed in general. But what happened when COVID-19 hit, there are two major barriers. The first one was the confidentiality issues, and the others are the payment issues. So in terms of confidentiality, CMS came out and basically said, well, we're not going to be doing any type of sanctions or actions for folks, no matter what type of communication network you use. So you can use what word like Zoom or Doxy or any of those and actually see the patient and do that kind of virtual exchange, or you could pick up your cell phone and talk to the patient that way. All of those are okay, and you're not going to, right? CMS has said during COVID, we're not going to hassle you if you're using any of these forms of communication. So that was huge, and it's a little bit problematic. And I've heard conversations with some of our behavioral health colleagues who are particularly concerned about it. But it certainly has opened up the floodgates, and for many of our patients who, as Casey was mentioning, are not really very savvy. That having the ability to just use your cell phone, I mean, it's huge. And frankly, that's where we should get. If you can deposit $1,000 check in your bank account with your cell phone, we should be able to figure out how to do HIPAA compliant activities with our telephone. So I think that will come. And we heard Rebecca talk about what that meant in terms of clinicians and the availability, being able to provide the services in a more convenient way. That this expansion is something that's really beneficial. The other aspect is the payment aspect, and so just to let's stay back on that other slide for a minute. So in terms of payments, so there's some various kind of payment models, and so prior to COVID-19, if you did a video visit, you got reimbursed more as opposed to a telephone visit. But with COVID-19, again, all of that was swept away, and so now you are reimbursed the same as a face-to-face visit, whether you do it by Zoom, by Microsoft Teams, or on your cell phone. They're all reimbursed the same way. So that was huge. So those were the two big barriers. One was the reimbursement aspect. The other was a confidentiality aspect, and both of those have been addressed big time. So that telehealth is just it's more than half the visits now in many settings. The other one that I'd like to mention, because I'm going to talk about it again as we think about the future, is an increased awareness of the role of public health. So public health has really been marginalized over the years. You look at how healthcare dollars are spent, 98% of it goes to individual healthcare services, 2% to public health. And yet you look at where the biggest advancements in life expectancy have occurred. Most of those are related to public health in terms of immunization, sanitation, various types of regulations to keep us safe. Seeing how important public health has been in responding to COVID-19, I'm hoping that there will be some spillover effect as we think about the future. Next slide. Okay, that's what we have right now, which I guess you could really call it the golden age for telehealth and MAT. I mean, you can just do it any way you want to and get paid for it, and get paid for it as you would any other visit. So as for right now, it's really not an issue. Whatever you're doing, you're going to get paid for it, and you're going to get paid as well as a face-to-face visit. Now, looking long term, I think there's a lot of questions, but I would start with this point. And regardless of what happens, if you can provide services more efficiently and effectively, in the long run, you're going to be in pretty good shape. So I would really focus our efforts on that. Right now, what we see a lot is where the tail wags the dog. So the way we get paid impacts how we provide care. And again, everything is kind of up in the air right now. So rather than trying to predict the future and what's going to happen and how the laws are going to be changed, I would focus on the fact that, okay, we can provide care more efficiently and effectively using telehealth services. Think about the kind of innovative things that Rebecca's doing in LA and Casey's doing in Monterey, and continue to try and optimize what we're doing with telehealth. So talking more specifically about what are the various options that are out there, there's the traditional fee-for-service avenue. One place that we can look at to embed telehealth services is in federally qualified health centers and rural health clinics. Currently, FQHCs and rural health clinics get reimbursed very well for their services, whereas a private doc may get paid $50 by Medi-Cal, and FQHC may get paid $200 or more. And what CMS has said is that, at least for the present time, FQHCs will continue to receive what's called wraparound payments. So they don't just get the 50, they get the full 200. So I think there will be fee-for-service options that are available for telehealth. And you can imagine ways that we could even optimize providing services, much as Casey's been doing, checking in on patients very regularly, weekly, whatever. We may run into the same issue we run into other aspects of healthcare, where there's issues of overutilization, where it's because you can do it, because that's how we get paid, that's what we're going to do. So I think there's certainly a risk of that. But looking at fee-for-service, and particularly at FQHCs, RHCs would be beneficial. In terms of treatment centers, there are CMS just came out with good information regarding bundle payments for treatment centers, with fairly lucrative payments for those that cover the kind of team-based services that I think we would all like to provide, that would incorporate folks like the substance use navigators. All of us are, probably the majority of us are here because of that we're receiving funding through CalBridge. And there's a reason why programs like this get funded by grants. It's because they don't fit neatly into other areas, or because they need the support. And I think when you think about opioid use disorder, it's one that doesn't fit neatly into our boxes. It's a medical issue, but it's also a behavioral health issue, and yet neither the medical community has fully embraced treating it, nor the behavioral health community. So unless dual diagnosis, a lot of behavioral health folks will say, geez, that's not my area. They need to get treated for substance use somewhere else. So it's one of those important areas of healthcare that doesn't have an easy home, and that's where things like grants come in, and to help meet those specific needs. And again, Rebecca was talking about some models of payment that grants can help support salaried clinicians so that they're not tied to kind of that hamster wheel model of seeing more and more patients, that there's other ways to provide services. And also to think a little bit outside the box in terms of how we do provide those services. But then thinking, returning to the theme of public health, that healthcare has been, the emphasis has been on the individual and on health plans and healthcare organizations. And yet communities have a role to play in this. And you can think of your community either county level, city level, regional, state, even at the federal level. And how do we reimagine how we provide services, and how can we coordinate and organize that? And again, I really like what Rebecca was talking about in terms of having several clinicians that are working together, maybe not necessarily in the same office, that can provide some 24/7 coverage to your various emergency rooms and other offices. So again, thinking more at a community level of how you're going to meet the needs of your community as opposed to meeting the needs of your own specific patient population. And then finally, thinking more from a medical model, there's been a emphasis on what's called value-based care, where healthcare organizations are responsible for both cost and quality in that model. And when you look at folks with substance use disorders, opioid use disorders, a lot of them are very high utilizers. They end up in the hospital, abscesses, CHF from meth use, et cetera. So they're expensive patients, and so a focus on managing them makes sense in a value-based care model or matrix. And again, as we focus on telehealth as a more efficient way to deliver care, there is a role for telehealth and MAT in value-based care settings. Next slide. And then finally, we went through a lot of information fast. So I've got some references here that you could look at. And so the first one is from CMS, where they actually, I thought, did a really nice job of explaining all the different telehealth options that are out there. And the second one was talking about some of the barriers that are still out there, such as restrictions based on location. So do you have to be in a rural area to access telehealth? Restrictions on payments as well as providers. So this was a kind of a primer on how you can break down some of those barriers to make sure that you're providing access to telehealth services as broadly as possible. And the final one speaks more directly about some of those bundled payments that are available through CMS. And we did a little research on some of the kind of the current state that we could provide as well separately. So with that, I'll stop, and happy to answer any questions, and thank you for including me.
Great, thank you so much. We have a couple questions coming in. We're looking for a little bit of a finer point on some of this legality. So Eileen Morley asks specifically, has there been any clarification on when the Ryan-Haight Act will be reinforced again? She says her hospital would be really interested in knowing about that. And then we also had a question earlier in the presentation, and the question that I wanted to pull out was, what do we think the odds are that we'll be able to continue doing telemat for the next several years in terms of legality? So those are related questions for whoever wants to take them.
I'll start. I mean, with the Ryan-Haight Act, so it was clear. In the Support Act that was passed in 2018, the intent, I mean, very clearly stated that it was to improve access and address issues with substance use disorder through telehealth. So it's very clearly the intent of Congress and signed by the President that we want to take care of this problem. And it referenced the Ryan-Haight Act. They want to address it. And then you had follow-up from DEA, HHS, CMS, State of California, all saying the exact same things. So as issues come up, I think we'll find that they will be addressed, and I think to a large extent they already have been. The one that diving into it was there's this registration component that was supposedly in there, but again the DEA said, well, geez, if you've got a DEA license, then that in effect becomes the registration process. So I really don't see it being a major issue going forward, and particularly now, as we've seen telehealth just skyrocketing. And one other comment about telehealth, one thing that was another, one of the other consequences of COVID is they've rolled back. First of all, CMS doesn't require patients to provide copays right now for telehealth. And the other is they eliminated the requirement that you had to have a prior relationship with the patient before you started to see them. And this, I think could have a number of effects. One of them would be opens up the door to national telehealth corporations to kind of swoop in and you know, kind of corporatize medicine. So I would just kind of be alert to that. But I don't see us going back. I mean, telehealth is just, it's too widespread. It's too accepted by patients. It's like by clinicians. It should be less expensive. And so I don't think we're putting that genie back in the bottle.
And Rebecca, did you want to weigh in on that?
I seem to have lost.
Yeah, I just consistently went back to what's the right thing for our patients in terms of these issues. And we developed a little bit of a letter that described what the Ryan hate was and all the legislation that was referenced that kind of permitted this practice. And, you know, not being lawyers, you can read these laws and get nervous, but I think really grounding all of these questions and kind of what we consider like mild gray zones, and just really re-referencing that back to what's the right thing for the patient, and really being comfortable moving forward in our practice of caring for very vulnerable, stigmatized population with current practice and current laws. And even after COVID, we anticipate if we return to our baseline that we will still have the same practice without any problems. The questions that I saw in the chat were about EMRs. I don't know.
Yeah, I was gonna call out some of these more weedsy questions. So go ahead, Rebecca, if you want to pull out a couple questions to answer. And also, we're getting a question from Cindy, our son at San Gregorio Hospital, about whether there's a policy for your hospital-specific telehealth policy. So we'll answer that question, and then anything else you want to pull out.
Yeah.
So go ahead, please.
We use a Cerner product, and we use a Cerner product for our electronic medical record, and we really, again, ground what's the right thing and try to make sure that we're not adding extra layers of steps on MAT that we don't do for other services. So we just have, for example, a one-liner in our progress note that says patient verbalizes consent to proceed with a telehealth visit, and that's it. We don't have a very complicated or like number of legalese points. And our patients get registered under the urgent care kind of modality, and that's in the same platform called FirstNet of the ER tracking boards. So
while she's coming back, that first document that on my last slide there is a CMS document that says in terms of patient consent, patients, that was about the only requirement they have right now, is that patients consent to the telehealth visit. But they say that patients, that you are allowed to remind them that they may, that this is available and that they can access it. So you can contact patients and say, you know, do you want this? It's not, it doesn't have to be initiated by the patient. So if you read that first document, very, very loose. And I think if you follow, if you follow the criteria in that CMS document that addresses telehealth, you'll be in good shape.
This is Casey. So we basically, built this in, less than 2 weeks. And it's kind of the one upside of COVID, if you will, is that we're allowed to innovate based on the need. And if I had tried to tell my hospital I wanted to do this, last year, they would have gone, no, no, and no. It makes no sense. And the need for innovation really drove this. So we actually don't have a formalized approved policy. Everything's been on an interim basis, but I can absolutely share. And Dr. Close, who's a regional director for the Bridge, who's at my hospital with me, can also, I think she's already shared some of those documents on kind of how we built it and the Epic Note templates that we've used. We actually don't write a traditional ER note. It's a modified ER note. We use a specific template that basically calls it an telehealth follow-up note, and our coding company knows to bill those as telehealth visits. So this is I got a question, the telemedicine side originating fee. So this is really interesting, and I can send out some information on this. But basically it's, and John, you may have more insight on this than I do, but this is all changing so rapidly. And for us, we built this not realizing that there was this telemedicine originating site facility fee, and we really moved forward out of a fear for an overrun of COVID patients requiring intubation in our ED and shortages of PPE. So that was really what drove it. And now that we're doing better in Monterey, and I can say that we're doing better as of today, we all know this can change at any time, but now we're kind of coming back and trying to improve. And that's where we're coming back to this telemedicine originating site facility fee. So there's a code, I can send out some documentation, but it's something that we're still looking at how it works and when we can use it and what does that mean as far as the bottom line of the hospital financially. But yes, it's something that we're definitely trying to build into our ongoing efforts.
Great, thank you so much. I'm watching this chat for a couple final questions if they're coming through. I want to thank these experts so much for being here with us today. And I think what I'll do on my end is we'll compile some of these key questions that you had and some of the documentation that you might need to make some of this happen at your hospitals and make sure that we share that out. Before we close today, I wanted to make sure that, believe it or not, as we've been on this webinar today, the California Bridge plan to fight the current loss of the BHPP funding has been rapidly evolving while we've been learning about telehealth implementation. So I'm actually going to have Aria Baylor, who's our Communications and Events Associate, talk to you a little bit about what to expect from us in the next couple of days while we have your attention. Aria, go for it.
During this call, as Elizabeth said, we move really fast. We have started a virtual rally to save the BHPP funding on Thursday, May 28th at 11 a.m. I will put the registration in the chat box, and I will also send it out to all of you after this event. So hopefully you guys can see this. We would love to see you there. It's about 30 minutes. We're going to have some great speakers and presenters to try and get us our BHPP funding.
And I know we have several SUNs on the call. So SUNs, just so you all know, this will replace your pop-up training currently scheduled for May 28th. Based on the calendar, we were able to pick that time when we knew we would have many of you engaged. So we'll be sending more information soon, but please know that at a time when we can't encourage you all to go to Sacramento and stand on the steps of the Capitol. This is going to be our virtual way of making sure the state knows how important this funding is to us. So SUNs will be encouraging you to share this with others in your hospitals, and clinicians will really be wanting to hear your voice as well. So we'll be sharing more about that. We will be continuing these virtual learning opportunities for you. The next currently scheduled one is in June, and it is on alternative to opioid pain management, which is a question that we've gotten a tremendous amount of questions about. Probably the telehealth payment and then pain management are the two topics that we've gotten the most amount of questions about lately, especially as many of your implementations for those of you at California Bridge sites have become more sophisticated. So we have a lot going on right now at California Bridge. Our conversation series continues today, actually, with Ariana Sampson talking about the role of PAs and NPs in this model. We're always looking for your feedback. So we do have this survey here. If you've used California Bridge materials, can take a moment to fill that out and let us know what has been helpful to you. And yeah, we have one or two SUNs chiming into the chat and saying, yeah, they're worried about this BHPP funding, so they'll be looking for more information about that rally. We hear you, we're working for you. I had this get waivered promotion for this free Get Waiver training tomorrow, it's actually past capacity. It had slots for 1,000 providers and it's now past capacity. So that's really amazing that there's going to be another 1,000 physicians who are going to be waivered after this online opportunity. If you are looking to get more providers at your hospital's waiver, you can reach out to me directly. And we do have several opportunities to join virtual waiver sessions hosted by Rebecca Trotsky-Sir, who was on this call. We also are working with ACEP. California Bridge experts are going to be working with ACEP on their own online collaborative to grow this model. And as a reminder, we do have our COVID-19 page, which is being regularly updated with all of this rich material that we've shared today. Any changes to regulations, anything that you might need to know to promote MAP via telehealth is being shared on that website. So you can bookmark that, take a look, and we will keep that up and updated for as long as we need to. I think that's about all I have today. I'm happy to stay on a few more minutes and take questions. Otherwise, I think we're right about on time. And thank you all just so much for your work at this time, and know that California Bridge is here for you in anything that you need. Reach out. No questions, small or silly or anything like that. And thank you to our experts and to ARIA for working in real time to put together this response to the budget revisions that we learned about last week.
Thank you, Elizabeth.
Yeah, thank you. Thank you all so much. I'm gonna give it another minute or two to see if I get any last minute questions. Thank you, Jen. Nice to see you. Yeah.
I was going to make one comment about the SUNS and as navigators, that they provide an essential function that is not limited just to opioid use. They're critical for our management of diabetics and CHF, et cetera. There is a funding mechanism called chronic care management that does reimburse for kind of more team-based approaches, and for non-physician, non-clinical folks who get paid for units of service. You have to have 2 chronic conditions. So with opioid use, that's one anyway, and so a lot of them have another. So potentially that's a way for SUNS to continue to play a role and to get reimbursed for their services. And it may require, they may not be able to do it as a standalone program, but perhaps thinking about other kinds of more comprehensive chronic care management programs that include substance use as a component.
Great, thank you for that. Yeah, that's something we're exploring, doing a little bit more education about that on some of the upcoming SUN trainings. I know that's something that a few of our SUNs have been able to successfully implement in their settings. So yeah, Jill says thank you for that. Yeah, that's really, really helpful, and that's a potentially promising mechanism for our SUNs. Any other questions? There's a lot of people on here. All right, I'm going to go ahead and stop this recording. Let's see.